My apologies. So we will have you on this panel. So it's Daniel Ruckers, PhD, President-elect Sacramento Valley Psychological Association. Please proceed.
Okay, so I'm going to speak from a private practitioner standpoint too, but as president of the Sacramento Valley Psychological Association. I'm also a board member for NAMI Sacramento. I've got three main points that I'd like to go over, and these are based on my interactions with my clients, with colleagues, and also with my biller, who has a special insight into the billing difficulties with the insurance companies. So the first thing is consumers still have difficulty understanding and accessing mental health care. Every day I listen to patients talk about their mental health care access. I have some of them call me. They don't know what their coverage is. They may not know that their mental health coverage is a carve-out, and most don't know what their benefits are. So I have to instruct them, okay, this is how it's got to go there. I was talking to a patient of mine this morning who used to be on the liver transplant list, had multiple organ problems, and I was talking with him about it, and he said, you know why a lot of times patients don't even call in? He says, because they don't know to do it, and they're also overwhelmed by their psychiatric problems that they're going through right there. In other words, they don't have enough resources to organize themselves to put it all together. Under this, consumers, also the idea of coordination of benefits or continuity of care. An example of that is that earlier this year, state workers used to be, for their EAP program, used to be on MHN panel, and that got switched over to Magellan. And I had a couple of them on that list as well. So in order to keep treating them, I had to attempt to get on the Magellan panel, and I spent some time attempting to do that and was unsuccessful. So for that reason, then, they did not have their continuity of care. So number one, some consumer difficulties. Number two, providers, and this is what I just referenced, have difficulty getting on and off of panels. Treatment's controlled, and sometimes practitioners get squeezed, and I think Melinda was speaking to this, pushing them to migrate off the panels. In other words, it becomes not worth it. So I was speaking yesterday, I run a consultation group for psychologists, and yesterday I asked some of them about it, and here's a quote from one of them. I attempted to get out of EAP in February of 2014, and after multiple attempts, 1.5 years later, I think I'm finally getting off the panel. The reason I think this is important is because, and I don't know this, but I think it's worth thinking about, is if you make it difficult for people to get off the panels can appear full. Controlling treatment, another quote from a colleague of mine, they cut people's access, they've stopped authorizations. I have to get on the phone with case consultation. They tell me I need to have clients journal and then say, okay, you have 6 sessions over 6 months. They've done it multiple times to multiple clients. So that speaks to that sometimes panels are attempting to control or define treatment. This happened to me a few years ago. I haven't had it happen in the past year, but this colleague said that it did for her. When you combine that also with some of the statements, what Melinda talked about, I think what it leads to is migration off the panels. It becomes more of a hassle, and so what you have is if people are specialized, their tendency is to go off the panel. Because they're specialized, they won't get paid very much on the panel. They'll be more in demand at just practicing fee-for-service. If it was me and I was running a panel or an insurance company and I wanted to make sure that panel was full or appeared full, I'd hire a whole bunch of new psychologists. You don't have to pay them very much. They're specialists. They may check every box. Or hire master's level practitioners, and they may check every box like what someone referred to earlier, that they do treat all these different things. So I think that's an important thing we have to look at is what are the specializations and are they being treated? So my third point then is that even professional billers have difficulty obtaining insurance information. So I asked my biller about this. She said, and here's a quote from her, insurance companies want us to use their websites for mental health benefits, but they don't list the information I need, so I end up having to call and it takes forever. This should be simplified and easy to obtain in regards to copays, coinsurance, and deductibles, and if our codes require an authorization or not. My statement is, if my biller can't get it easily, that's her full-time job, how am I going to do it, and how is a patient going to do it? My experience in this also has been that when I have tried to get some single case agreements, it's a hard process, and the insurance company has asked me, well, what's the diagnosis code? I have to have a diagnosis code. I'm trying to get a single case agreement and I haven't even seen the patient. How do I give them a diagnosis code? So I'm not trying to blame the companies, but there's something there we've got to look at. That part's not working. And then coordination of benefits. My biller also said, Covered California has been frustrating for my clients because they seem to have issues with coordination of benefits. When a patient switches insurance, the information does not get released and the claims are denied because the new insurance still shows that the old insurance is primary. This becomes a nightmare. So it sounds like the handoff is not clean when they're switching between insurance carriers. So my three areas then, again, consumers have difficulty understanding and accessing. The second is it's being difficult for providers. And then the third is that even professional billers have some problems. So thank you very much.
Thank you, and I do apologize for the mix-up. We will open up any questions from any of the members.
For the panel, maybe in different perspectives, we're implementing the mental health parity enforcement in the department. And what kind of approaches would you take to be effective in implementing the federal and state mental health parity laws? What kinds of things do we need to do to ensure people get adequate services?
First, clarifying the benefits. So a patient and a patient's family know precisely what's in their plan and what's not. Clarifying who is available to see the patient. So having a very clear provider list that's accurate, that's up to date, that can be online or nonetheless, or if not, at least readily accessed by telephone. So what are the benefits? Who are the providers who can provide this? And then look at the hassle factor, which is very different in mental health compared to general physical health.
Talking about like utilization management?
Utilization
Medical
review,
necessity.
all of that kind of stuff that comes with an attempt for reimbursement for care. That's huge. More providers, obviously, is huge. That's been referenced already today, and that is a clear issue. How can we go about that? Well, there are a variety of ways that are possible, certainly. Train more psychiatrists, train more psychiatric nurses, train more physician's assistants. There's a program that specializes in physician's assistants in mental health care. That's important. What's also important is allowing psychiatrists to do more consultation. When my patients can't see me anymore and they see their pediatrician who can provide the medication, I consult to the pediatrician. Unfortunately, there is no reimbursable code for doing that. And so it's my time and the physician and the pediatrician's time spent on the phone. I would do an awful lot more consulting, as would my colleagues, which could expand how many people we're able to treat. If we have the ability to do consultations, in theory, that's coming with the Affordable Care Act, but it certainly isn't there yet, and there is not yet a utilizable code for consultations like that. There's a few issues.
I would echo those sentiments. I think the key thing is we've got to make it really clear and easy for patients to find out what are my benefits, how do I go about utilizing them. Because I have had very few people call me up and say they want to get in to see me, and they have checked or know all of the elements of their plan. I think it's too difficult for them, and I think that's a real problem.
One thing I would like to add to that as well, and then I'll pass it down to my colleague, is an easy and transparent appeal process. that is about as obscure as one could imagine. Although it is said it is transparent, it is very hard for patients to find what the steps are, even when I coach them every step of the way.
Yeah, just to add to that, you know what? It's very clear when things like that work. I know there's been a lot of Kaiser bashing today. Kaiser has its problems, but Kaiser also does some things very well. And when it works well, it works very well. So when there's a process that works well, people know that it works well.
Okay, any other questions?
I wanted to hear Kaiser
sorry.
if they had any.
Go ahead.
Thanks, Senator
Don?
Bell. Yes, sir.
Go ahead.
And thank you for that. I guess I would look to the kind of data that is being collected. Director,
The HEDIS and all that kind of data, or?
well, I mean, that's outcomes data, and that's useful, and we do well on that. But I was actually talking about, Director Rouillard mentioned how she thought we were victims of our data in Kaiser, and I look at it differently. I just say we have really good data. And so when you're talking about timely access, for instance, we're measuring from when the patient called us, which we call initiation, to when they're seen, right? The regulations are initiate to offer. And then I know a lot of other health plans are really struggling to come up with, for lack of a better word, real data. I guess I'm taking advantage of no other health
Talking
plans
about
being here.
medical technology.
Well, they're measuring it by secret shopper methods and things like that. And when we report to the DMHC, here are the visits that happened in this month, and this month, and this month, and here's the percent that were within standard, and that's.
When the parity law went into effect and then the implementing rules came out, some of the plans made comments on a national level. They were saying, well, we want to, whatever we do here, we want to make sure the rules are clear, and then as long as we have a clear set of rules, we can follow those rules. Then there'd be less, disputes, that you wouldn't have to, the number of disputes would be lower. I think one of the goals that I would personally have is to make the rules clear enough so that we would lower the number of disputes that take place so that people wouldn't have to go through, I guess you call it the hoops. And it seems like a waste of money to spend money on disputes rather than patient care. It only delays patient care also. That's the other part of it. As delays occur, acuity gets worse. The patient doesn't get better unless they're treated, unless you have a good plan for treating them. So I think is that something you would agree to?
I think if you are monitoring the number of disputes and expecting plans to bring those down, that can be useful. And I think if you're expecting plans to make it easier, solve problems.
I'd like to know what you think we can do to make the disputes go down. I mean, what kind of, that would be my, to help the families and then your plan members.
Yeah, I'm tempted to harken back to the DMHC because they receive those and deal with them. I think we take them seriously and review them and try to deal with them, and we try to deal with problems at the point of care. I think expecting plans to decrease them.
What I'm saying is the earlier intervention, the less, when the people come in that we're talking about, in this case, a teenager with a mom needs to deal with that, and then an unexpected elder woman who came in and started having some confusing difficulty with her medication. The earlier we could have intervened on those cases, the better the outcome might have been, I would think. I mean, so from a medical standpoint, the right way to treat that person is to try to intervene as early as possible and not have dispute processes in place to put up a barrier to that. So that's kind of the thought I have, and I think the plans would save money if the person didn't have higher acuity. That the savings would be in that. So that's, I don't know if you have any thoughts on that, anybody. That's,
I think it's important also to think about is that, is it a system-wide problem or is it more an individual plan problem that goes on? So is it a system-wide problem across all the plans? And if it is, that's probably going to dictate a certain type of an approach versus if it's just a more isolated problem within a plan.
I think that, yeah, I think the Affordable Care Act and the mental health, the Federal Mental Health Parity Act, when you look on the face of it, does appear to be kind of confusing for a state government and a plans to implement. I would say that it's complicated. So how, given the fact that it is complicated, how do we make it easier for our people in California, you know, so we can treat them properly?
I think also greater clarity in exactly what is covered and what isn't. Greater clarity in what constitutes medical necessity and what constitutes each level of care, each level of severity. Once that is more clear, it's easier for patients to know what they have access to and what they don't. And if it does go to appeal, the appeal process can become more transparent as well. And so that should cut down on either people who leave the appeals process without getting their needs met or push the process on and on and on, only to discover very late in the game that they really didn't have the coverage they thought.
Yeah, okay.
Senator Mitchell?
Thank you. Thank you, Dr. Young, for that, because as I'm sitting here listening to Senator Bell's, inquiry and push, I think that's where we get this kind of balancing act between a health maintenance organization or a health plan that is a business model versus a health care provider. And we've seen it in the Medi-Cal program where we've tried to remove barriers to care, which are put up to limit the number of people who can access the care and therefore bring costs down. And so this notion of, being able to drag it out or challenge coverage, it tragically sometimes saves money, which is a different lens than which you view it. To Dr. Young, you mentioned that you didn't have rates, the comparison rates for California. You gave us rates for Connecticut and another state. Is there a reason you don't have California rates? Are the appropriate state entities not providing them? I was just curious about that.
I'm not sure how the American Psychiatric Association got the information for Florida and for Connecticut. Mm-hmm. Randall, do you know?
I think they went through individual providers just one by one.
Got it. Okay.
And because there are so many potential providers and so many health plans, getting that kind of information, I think, does need to be done on an individual basis. And so I think they committed the time and I think they committed the personnel as a psychiatric association to look at whether parity law was actually being violated or followed. We have not had the opportunity to do that as an organization yet. It would be lovely if an agency that actually had access to reimbursement rates could do that centrally.
And the reason I ask is a follow-up to several questions Dr. Hernandez and others had in terms of looking at barriers to the number of available beds in California. If reimbursement is the issue, that's something that would be helpful for us to know. On that same note, you talked about ER stays, and I just wanted some clarification. Every emergency room that I have visited in my district, both in the Assembly and the Senate, raise this issue. You meet with the ER Docs Association, they raise this issue in terms of their inability to perform, for the lack of a better term, traditional ER work based on the number of mental health patients that are there because they have no place else to go, quite frankly. And so you mentioned some pretty extreme lengths of stay. So I wanted to make sure I heard you correctly. And you mentioned 60 and 90 days?
71 and 90. This is from information provided to us by emergency room physicians and colleagues who work within the hospitals themselves. 71 and 90 was what I said.
Okay, so let me make sure I'm following this. This is, I am a patient, I go to my ER, I clearly am a risk to myself and others, whatever the classification is. And because there is no mental health bed in that hospital, they can't find one in any other hospitals or a locked facility or something, I stay in a bed in the ER for over 2 months?
You cannot be released if you have not been stabilized. And so they need to keep you until you are stable and safe to move elsewhere that's appropriate.
And so that I am in a bed in an emergency room for 2 months?
Because I don't work in emergency
Okay.
rooms. I cannot give you an absolute personal observation. This is information provided to me from emergency room colleagues.
Got it. Thank you. And to Dr. Rockers, as I listened to you and I thought about it, the reality is I think that most people don't know what their health coverage is across the board, quite frankly, until you need it. And then you discover you don't have it or it's not quite what you thought it was. So I think that's a general issue across the board. But what was so telling to me in your comment is what may be different as we talk about parity to healthcare services is when you are experiencing a mental health crisis, you don't have the capacity, if you will, to fight and advocate for yourself if you're in the middle of a crisis. So that's what makes it different. And, as I thought about it, we deem any number of conditions presumptive eligibility. We did presumptive eligibility for pregnant women decades ago. If you present in an ER and you're having a heart attack, they treat you and ask questions about coverage later. And so I'm wondering, as we really talk about parity issue, if we need to think differently about how we provide for or pay for services for people in crisis. And so it can be people other than the well-to-do, highly educated, probably white, upper middle class family that we're able to navigate the system that your colleague talked about.
Or have somebody who can navigate the system for them. Absolutely. I think what it brings up, again, is that accessibility thing. Whatever people ordinarily would do for regular medical coverage in such a situation, it should be the same procedure for mental health coverage. Because they at least can do that. They at least can organize to get that part.
And if there's any presumptive eligibility allowance, I wonder, for the person in the ER for 70-some-odd days. I wonder if for some of those, if it's a payment issue and an access issue, it's probably a combination. Thank you.
So I just have some comments, and I want to kind of follow up what Senator Mitchell said about parity and perhaps this being one of the stumbling blocks to it. And I guess my biggest concern would be that of the patient getting access to mental health, and then, first of all, knowing what what's available, but more importantly, to actually get the access to that mental health. And I think both of you, you made that first, Dr. Young made the first statement that is probably the most concerning, is her physician colleagues that do physical health billing, they don't ask them for prior authorization, they don't ask them for a charting, they don't ask them for a progress report, et cetera. If you bill for a removal of a whatever, a tumor or a procedure, they bill, they get paid. And then one thing that's kind of stuck out me today, and I think the first presenter, Patricia Wenzel, mentioned it, and I think you mentioned as well, is increased transparency on the appeal process. And I think that's something we have to look at to make sure that this isn't one barrier to the limited number of providers that we have to begin with, that if a patient who is having a crisis in their life, that they can get services. And then the other comment that I think you made as well, Dr. Young, was the 99213 code, that you get paid significantly less. And these are standard CPT codes that it's based on, like there's 99212, 2, 3, and 4, and it's based on the level of time that you spent with a particular patient, and that's even more disconcerting. So there's no questions, there's just a lot of comments that I have with regard to it. And I think this is one of the issues that deals with how patients don't have access to mental health that we need to deal with as well. So with that, I'd like to thank you for your comments. We are now going to move to public comment. if we can have, which speaker do you want them to go to? Yeah, we just public comment. If you can just state your name and just,
Oh, God, I have arthritis. I don't know about that. Can I sit down?